the physician to stay healthy. All right. So thanks again for inviting me. I was asked to talk about innovation in coronary stents. All right, these are my disclosures. All right, as we know, the MACE after metallic stents is increasing, especially after bare metal stents. And that was led to the bringing to the drug-eluting stents. But despite that, the metal, I think, still continue to be the problem. Either the polymer thickness or polymer design continue to be an issue in terms of long-term patency and target lesion revascularization. There is different iterations of stents has been produced that focus either on the strut dimensions or thickness or even the drug that is eluted, which is, for the main focus is just to decrease the target lesion revascularization. As has been shown before, for many years, stent thickness always impact time of course and extent of endothelial strut coverage and healing. So the thicker struts it is, the less drug is delivered and the less patency or efficacy. And the strut dimension increases for sure acute thrombogenicity and has been shown in multiple trials. And that in one meta-analysis, for example, the thinner is the better. And that favors less thrombosis, less TLR, and less target vessel revascularization. The ultra-thin has been developed in recent years, especially with bioresorbable compared to the contemporary DES, and meta-analysis showing, as you see here, favoring thinner strut or ultra-thin. It's associated with less TLF, myocardial infarction, and stent thrombosis. So I think for any stents design, I think these are the four main domains. Is the strut thickness, stent geometry, polymer type, and eluted drug. This is has been worked on in different domains, different stent designs, and different companies. Starting with Synergy Stent, this is a platinum chromium metal alloy platform, a 74 micrometer. It's with increased flexibility and deliverability as well. It has a everolimus, and that is released over the course of 3 months. And also it's the absorption of the albuminyl polymer in less than 4 months. So this has been studied in Evolve-2 study comparing to Promise stent. And over a course of follow-up at the 5 years, it was not inferior to the polymer stents. And therefore, with a TLR after 1 year is close to 2%. Similarly, moving to the other designs, Orsero stent that has been studied heavily in Europe as well as in the US. This is a cobalt chromium. It's 16 micrometer, and it's struts. And it has bioabsorbable polymer, sirolimus drug, and the design is very passive coating, prevent kind of corrosive process during deployment as well as down the line. So if you want to compare this stent to the science, it's thinner, it's bioresorbable, it has 16 compared to 81, and the drug is different. So when they studied that in a bioflow study, they followed the patient also for 3 years, showing that Orsero wasn't just inferior, and also has some superiority in patency as well as target lesion failure at 3 years and 5 years. And also an MI showing superiority of the Orsero compared to the Xience. So again, goes to the point that thinner is better. I don't think the drug difference has played too much here, but I think it's the strut diameter was the main focus. Even at late and very late, which is defined after more than 30 days and less than 2 years, was comparable in both stents. So this is again go to the fact that thinner struts and bioresorbable perform as good as the polymer. And then in other study, BioResort, that has compared the 3 different commonly used stents, the Synergy, the Orsero, and Resolute Integrity. This patient has been followed also for 5 years, showing non-inferiority of the tacrolimus as well as the everolimus, but perform a little bit better compared to the non-degradable polymer. At 5 years as well, there was no difference despite some variability in antiplatelet compliance. I was able to pull this paper just published recently about the patient who has a small vessel defined as less than 2.5 millimeter, and the performance of thin struts. And for sure, this is kind of concern for all the physician who has an OM, which is 2 millimeter, or like a diagonal that you worry about jailing. So therefore, the bioresorbable performed really better compared to the non-degradable polymer. Moving along to a BIONYX trial that compared Resolute Onyx with Orzero. This is again a new design, thinner, and also is more radiopaque. You can able to see it better. So again, the comparison between two stents, there was no difference in target vessel failure, but the Resolute Onyx performed slightly better compared to the Orzero in regard to the stent thrombosis. Strut geometry also important. So the shear strut that is developed on the wall artery and the artery wall is also has been focused on recent designs. The different shapes of shear stress can induce stent thrombosis down the line. So there is a new cylinder stent that is a very small profile. It's a lowest profile drug-eluting stent system available at this point. It can be delivered through a 5-French diagnostic catheter. And as you see here, it's a really small profile, and it's already loaded on the wire, and it's crimped across a sectional profile, and it's really resorbed in 12 months completely. So this is one of the, I think, potential stents that can be helpful for small as well as large arteries, and also has a smaller. In terms of the study that is, it's Optimized International, one of the, it's running in the US at Cincinnati, and Durham, Nasruddin Rao, and Dr. Kuriakis are the PIs, and this will be enlightening to see, especially in patient who has vascular complication or calcification. You are using a smaller guide, probably that would be delightful. The other one I would like to bring to attention is DynaMACE, which is a stent that has uncaged element. Strut thickness is 71, so it's still considered in the ultra thin, but its drug rating is in 3 months, and polymer degrades in 6 months. The difference in this is the shear stress on the wall. By keeping the mean lumen area the same during and also after, which is a concern for during deployment, as we're stretching that artery, the artery recoiling. But in these stents here, they have been shown in animal model that the lumen can be maintained throughout the therapy and after the stent is completely resorbed. And the DynaMACE bioadapter, it restores physiological visual angulation and as well as reduces geometric distortion of the artery. This has been also running in a study right now, results to be presented, but this is one of the example showing that's a very calcified lesion, mid-LAD, showing it during, at baseline on the left, and at 6 months, although there is no difference in recoiling or the visual patency, and the angulation of the artery is kind of went back to the normal, which is one of the important factors for stent thrombosis as well as TLR during stent deployment after long follow-up. Another example here, this is again from the slide from the PI, showing again the curvature of the artery completely maintained after a few months of the therapy, which tells how durable it is and how it maintains the lumen after a few months. So in summary, stent strut thickness is a determinant of the clinical outcome for TLF as well as stent thrombosis. Thinner, everybody agree, thinner is better. And bioresorbable stents are differentiated by strut thickness, polymer composition. Probably distribution and load and time course for resorption is different, but still it's not sure how this is going to play into a long-term follow-up, especially for a patient on short or long-term dual antiplatelet therapy. The DynaMACE I showed you preliminary data suggests device and novel and visual growth, lumen area kind of preserved, as well as the curvature and shear stress on the artery wall. And caging may be reserved pulsatility, cyclic strain, and positive visual remodeling. Modification of the stent struts and geometry may mitigate differences in strut thickness and require further study. Thank you so much.